So we do, we come from the front, go into the foraminal valley basically, and just hit it with this high energy radio frequency. And that's for more atypical facial pain too. But thinking about it for depression and all these other things, there's a big movement out there to use things like stellate ganglion blocks.
Oh, I'm sorry, that is what I'm talking about. Stellate ganglion, not ganglion gastrary. I apologize.
Oh, yes,
Stellate
stellate ganglion blocks. We've had people come and they want it for post-COVID, they want it for depression, PTSD. I don't know of any good data that says it works. It doesn't make any sense to me that it would. I mean, it's a unilateral sympathetic block of the head and neck and upper body, you know. So why would that change depression?
Let me show you something that's very interesting, David. I just Googled stellate ganglion. See who comes up. You. So stellate ganglion block neuropain clinic. Good job on that.
Thank you.
Yeah.
That was Navneet, right? That was Navneet and
No, see, especially, I mean, Dr. Fleeman, who's going to come and talk about it, it seems that he has some good information about, you know, that the taste block or taste post-COVID taste, the loss of taste and lots of different things. And I myself don't really know about that. So I'm really looking forward to hear about what that is. Another subject we are going to talk about is about ketamine treatment, post-surgical and pre-surgical ketamine treatment. And as well, there are some other people are coming. Dr. Samadani has agreed to talk about post-traumatic spinal cord stimulation device placement for pain management and so on. So we are putting a good group together. So if you guys like to talk about any of the special thing you guys do, we would love to add you to that.
Yeah, but, we do ketamine for complex regional pain syndrome, and it works pretty well, but it's not covered by insurance. And we do like 4 hours of an infusion, and it pays like $80 or something. So
not very high pay, but
there's ketamine in clinics that are like out of pocket, and they're $500 to $1,000 a session, and they're thriving for all sorts of reasons.
So would you like to give us your experience on that and your best information on that you can provide on that? I would love to know as well about your clinic, you and Scott, if you like, if you can and like to talk about some of the advanced new stuff you guys do. We would love to know all about them.
Yeah, there's a lot of interesting things happening. There's movement like psychedelic medicine where they're using all these things.
You just talked about that. I cannot let you go. So I'd love to know about. I know that that there are some even older. These are older studies that not only psychedelic per se, but specifically LSD for post-traumatic stress syndrome, for new things. I mean, do you mind to give us just 10-minute talk about this? I know like electroshock therapy, psychedelic, ketamine, some other medication that they give it, like a idea is to reset the brain on a new ways and so on. I remember, that.
Sure. I mean, I'm not an expert at it. I'm very interested in hearing about the studies and so on, but to me, it's like back to high school,
So what are the things you do yourself in that besides ketamine?
In our clinic, we just do ketamine, and it's mostly for pain and in work comp where we can get paid for it.
Okay.
And we do stellates for PTSD and post-COVID if they pay out of pocket.
Okay.
So it's not covered by insurance, but sure, we'll do it. It's simple and easy.
Yeah, that is. So talk about anything you like to talk about, but specifically talk about that you are currently doing. So I'm going to present, if you guys are okay, this 70-year-old gentleman who is very active in life and has practically a recent onset. David kicking with the clinical information after a wakeboarding incident. What seems to be first S1 and later L3 radiculopathy, but as well some quadriceps weakness. This is a recent development, to my best knowledge, and
like 3 or 4 weeks.
3 or 4 weeks. Yeah, so not years of clinical findings. So
And previous laminectomy in 94 at L45 for
L45 right
extruded,
here.
yeah, for an extruded disc with radiculopathy.
So
And that-
here's
and
some
asymptomatic.
scarring here. Here seems to be some scarring corresponding to that previous laminectomy. Was it a full laminectomy, or was it seems that there have been maybe a hemilaminectomy, not a full.
Yeah, hemilaminectomy and discectomy, pretty
Yeah.
minimally invasive.
So, Bob, I see you are online. Do you want to comment on this and ask for new other medical information? Oh, maybe Bob is driving, and I see an iPhone. I don't know, Bob, you're muted.
Bob, you're muted.
Oh, maybe if you're driving, you should pay attention to driving. You don't want to cause any accident.
Okay, are you there?
Yeah,
Can you
I'm
hear me?
here. You're here. You're here.
Okay, I stopped and I'm looking. Well,
Back and
first
forth.
I see 3 discs that are extensively collapsed. I see
Right.
L34, L45, L5S1 very collapsed. Then could you do a sagittal scroll side to side for me? So the foramina are really bad at L5S1, and then they are relatively bad at L34, and there is stenosis at L34.
Yeah.
What are the symptoms? Which part of the leg is hurting?
Yeah, it is David. You can give us some.
Sure. So initially it was axial back pain on the left. Then it was the L3 and the L4 dermatomes, upper leg.
So we are talking about
quadrip.
which side and front of the thigh? You're talking about pain front of the thigh going not past the knee, correct?
Yes, and left side only. No right-sided symptoms.
Okay. Well, that is what dictates the treatment, I guess, because I mean, we are not treating the MRI, we are treating the symptoms. So I would concentrate on the L3-4 level.
Okay.
And I would, can I take a look one more time? I'll tell you what I would do. I would do 2 things. Foramina fairly tight. I would probably do an olive there and microdiscectomy at L3-4 left. That's what I would do.
Yep. As you see here, Bob, can you mute it?
Sorry. So I think L3-4 microdiscectomy and L3-4 olive I would do.
Okay.
And I would do it probably in one sitting, but I would use tubes, and I would do the microdiscectomy through a matrix tube.
Sure. I mean, obviously after fails, correct? Yeah. Okay. So as well here, you see the axial view. There's a sequester there. Let me see the corresponding line there. If I can get the corresponding line visualized there, but it seems that if you look carefully, there seems to be a sequester right here, but in startup, it looked like that sequester coming from 2-3, not from 3-4. And I'm going back and forth. Obviously, you see the hyperintensity in the facet. So facets are not really happy either. And I'm going up and down here. So I see an iPhone, but I don't know who that is. I think that's maybe.
Hamid, please, could you put a cross localizer on there so that we could easily see?
I'm trying to.
Thank you.
And while you guys are doing that, I'll say the radiologist read an L2-3 extruded disc herniation 15 millimeters caudally extruded.
Here.
Yep.
That's what it is here, right there. Right there.
It's a
That's
2-3 disc going down to the 3
Yeah,
nerve.
that's a caudally extruded sequestered disc, what seems to be from L23.
Yeah. So that means L23 microdiscectomy and L34 TLIF, OLIF, I mean.
Yeah,
I would do.
Who's on that iPhone? I think if you want to comment, I would love to hear your comment about
I'm right there.
No, mute yourself, you're echoing. Okay, so Sunny, why don't you take while somebody else is taking a shot at it? What are your suggestions here?
I think this is basically extruded disc from L2, L3 dropping down, circling around the pedicle.
Mm-hmm.
And the date of the MRI is August 3rd, 2023. Unless there's a severe neurological deficit, many of these things resolve on their own.
Yeah.
You don't need to operate on them. So I will give plenty of time. I know, David, this is you. So if I were you, I would not do anything. Just walk around and just baby it along. And there's good chance in about 6 weeks that the disc will reabsorb on its own. This happened to my dad actually at 2-3. As we age, the disconnections move up. Younger people get it 5S145. As we get older, the lower levels get stiff. It's almost like adjacent level disease.
Yeah.
2-3, 1-2, 3-4 herniations are people who are much older, 50s, 60s, 70s. So David, you're in the right age group. So my advice to you is not do anything. Baby it along at least 6 weeks until the thing goes away. If it does not go away after 6 weeks, 2 weeks, 8 weeks, just do a microdiscectomy 2-3.
Yeah, but what the quadricep weakness? He just fell yesterday. Quadricep weakness.
It's pretty subtle. I mean, I can walk around, it's just
Okay.
not as strong as my right.
Okay.
So that's a little more ominous, but if it doesn't get worse, I think it's fine. I can function and do
Yeah,
everything.
yeah. So
I will stop wakeboarding though.
No more fun for you. No more fun for you. No, motor weakness. As you know, the motor neurons are the most the most heavily protected neurons. They are, and obviously for a good reason. And if you start having weakness, obviously, follow up the weakness, see if the weakness is getting better. Most of the time it will. And obviously, conservative therapy is always the first thing to do. And you told me that after an epidural steroid injection, that is actually getting better. The pain is getting better. But, and the next step would, but you have two distinct, in my opinion, you have two distinct problems. One is that sequestered disc that correspond to your L3 radiculopathy. But another one, look at the stenosis here, right here.
Wow. Yeah.
Central canal stenosis. I'm going down here. You're right there. You see that there?
Yeah.
That is a quite significant central canal stenosis that I would say is a different second problem. And that, as well, you have to watch how the symptoms are, and that would correspond more to L4, 5S1 kind of symptoms. And that there as well, if you look carefully here, you have a spondylolisthesis as well. It's a grade 1, it's not a very severe, and that would definitely, if it doesn't get better with conservative management, would definitely would justify a fusion of any kind. Spondylolisthesis is a typical indication for, but doesn't mean that that's the only option. Okay, if you get a flexion extension and the translation is not too much, if it's not a mobile listhesis, that could be still amenable to a decompression alone. But on the other side, if you can get a surgery that is as efficient as a decompression and be more permanent, that definitely would be an option for OLIF if conservative therapy fails. Now, But more concerning for me is look at the hugging facet. You see that there?
Yeah.
Yeah, this is when the facet, and that is what I think Sunny was referring to. When we get older, our spine actually start becoming less mobile. And that is part of that is the disc becomes stiffer. Part of that is that the facet, they grow around each other. We call them colloquially hugging facet. And that reduced motion is actually a good thing. And that is why, as Sunny was mentioning, the advanced age, the higher level are more prone to problem than the lower level. So
is it right to assume that OLIFs at 3-4 are probably easier than maybe 5-1 or 4-5?
Well, 5S1 is different. Every other level is more or less the same. Would you agree with that, Sunny? 5S1 is more difficult, but the other levels are equal in the performance, right?
I agree. Yes.
Okay.
Okay.
I just did one of that for L45. That I want to show you actually that picture of that patient and discuss that maybe next. Yours is by far not as bad as this patient. And Sunny, do you have any case you want to discuss before I put the other films on?
No, go ahead. I
Okay.
don't really. No.
So I want to discuss actually two cases. One case is this case just from yesterday that we performed the one-level fusion on this patient in our own surgery center. So as you see, this is a much bigger pathology than yours, right?
Yeah. Wow.
So, and this is almost, not almost, if you measure it, it's probably 25%. I would probably call it grade 2 spondylolisthesis, completely collapsed disc. And obviously, even in this patient, we finish conservative management first. We don't jump to surgery. It goes through everything, the typical back pain and so on. And lots of knee-jerk reaction here is to do laminectomy and then fuse. And that part, doing laminectomy and then fuse, that put that patient on a path to open surgery, which is, I'm not saying is a wrong surgery, but do we really have to do that or not? Okay. Now, some as well just look at this film and say, is that maybe autofused? Do you need to do osteotomy to do this surgery or not? Obviously, I gave it away that we did this surgery yesterday in our own surgery center. So obviously, we didn't do laminectomy or osteotomy in our own surgery center. But let's just discuss it based on the face value. Sunny, what are your questions regarding the clinical presentation or options that you may have for this patient?
Well, I think question is whether there's it's autofused. Doesn't look like it's autofused. It's hard to see in one cut, but I'm sure there's some motion. And because of collapse and listhesis, I'm sure there's a bilateral 4-5. I'll be more concerned about exiting L4 nerve root rather than traversing L5 nerve root, given the anatomy there.
So Bob, and I apologize. Somebody's on the iPhone. I would love to know who you are, and if you like to be involved in the, giving us some opinions. It doesn't say anything but the iPhone. Can you unmute yourself? And John, do you know who that is?
I do not. I've been asking him to unmute as well as to start video.
Okay, Bob, what do you think about this case?
You're muted, Bob.
Yep. So, but since Bob is, I think, driving and he's muted, Sunny, what would you do with this patient?
Well, I mean, you do all the conservative measures and everything, and definitive treatment is surgery. I would do a, I would pose to the general public, would you like to have an open heart surgery done, or you would like to have a cardiac stent put in?
Mhm.
What we are doing is putting a cardiac stent in, where most of other people are, doing a coronary artery bypass surgery. So I would vote for the minimum invasive, basically interventional radiology procedure rather than an open surgical procedure.
Yeah, and I agree with you. Obviously, that's exactly what we did here. But doing OLIF in a case like that is not trivial. As a matter of fact, it is generally hard to do when you have a drop like that
Mhm.
to do regular OLIF procedure. There's-
Actually, Hamid, I did a case exactly like this in Crookston Monday, my first case. It was ischemic spondy, about 25% slip, looked exactly like that L5S1, okay? And I did it, and I did it in about an hour. And as I was doing second and third case, I got a call from the nurse that patient has a foot drop. Okay, so I checked up on her, and she indeed had a foot drop. Lots of tingling. L5S1 is more high risk. Ischemic spondy,
definitely is.
25%.
Definitely is.
But patient, what I was surprised was that she really liked the fact that it was minimally invasive. She still went home in 2 hours and after the surgery, and her question was, "Doctor, when can I go back to work?" I said, as soon as you need to. Foot drop will most likely recover. I mean, we didn't have any incident during the surgery. I mean, I got the thing in there, 3 milliamps, 4 milliamps, or whatever, but it was L5S1. So
Yeah,
L5S1, it's
It
a
has
higher
higher
risk
rate.
procedure.
And you
Exactly.
just have to consent the patient. Do you want to have
yeah.
a surgery that you
Well,
recover from it in 2 years? Or do
Yeah.
you want to do a minimal invasive, go back to work, but you may
Yeah.
have a higher rate of, especially L5S1 for the
Yeah,
foot.
she was a pharmacy technician, 25% spondy, just like this, but
Yeah.
L5S1 and, but this would be L4, L5 at much less risk
Yes, it is
of that
actually.
happening.
So, but
Hey, how much
surgery-
do you try to reduce the spondy? I mean, do you try to pull it back in alignment a little bit or not
well,
really?
to some degree you can, and there are techniques that enables you to do that. You would be surprised though. Now, when I was like 10 years younger or 15 years younger, I would do everything I can to make this picture look pretty, meaning that reduce the spondylolisthesis as much as possible. Now, with being 15 years older, I notice you don't need to make the picture look perfect to give the patient clinical improvement. So I'm concentrating mostly on the clinical improvement, and I'm way more successful now than 15 years ago. To a certain degree, you can correct the spondylolisthesis, but to make that picture look perfect, you have to do bilateral facetectomy, possibly osteotomy. To make that picture look perfect, you have to do 10 times more surgery. So, but I want to show you what I did. John, can you please, okay. So this is another regular OLIF. This is another technique, we call that MIS, direct lateral interbody fusion, MIS DLIF. And the hallmark of the MIS DLIF is that you are, in this view, as you see, you are way anterior to the border of the bone. And in the lateral view, you are just at the border of the vertebral body. As you see here, these are corresponding pictures at the AP and lateral at the same time. And I am not in the Cambin triangle, because in the Cambin triangle, the tip would be farther into the bone. And this would be up here, exactly at the border of the bone. Here with the grade 2 spondylolisthesis, it's not that clear, but that is what it is. Now look at that. Now I enter the disc truly anterior to the border of the bone. As you see here, I'm still lateral to the border of the bone. And then when I put the dilator in, look at that, it opens it up. That is all the proof you need that this level is not fused. And then I pack it, and then I put a cage in, and this is the end result. And as you see, this bone were on bone, they are not anymore. Look at how big the foramen is. And certainly the spondylolisthesis is not corrected. But yet, this patient woke up, the leg pain was gone, and about 2 hours after the surgery, this patient was discharged in a surgery that was only 30 minutes. And this is the end results. Now, some people, and some of the ways I try to correct that is that, I put the screws, as you see, I put the prod screws in the L4, and sometimes I try to correct some of the listhesis with the rod, slowly reduce it to the rod. In a one level, that becomes really difficult. In multiple levels, if I really wanted to reduce that, I would have put screws as well here in the L3, then put a rod in to the shape, and then slowly, serially, sequentially would have tightened the caps. When we put these screws in, they have a tower that, like, they have threads, goes 2.5 times higher than the size of the tulip. And then we can put it in, and we can put caps in and slowly reduce the rod. But in this case, I decided, I just want to do a segmental one level, so I didn't do that. Now, and this is the end results, which you see the size of the foramen is huge. The foramen is really open, and that is what gives them clinical improvement. Now, this is much worse than your case, David, okay? But this surgery was 30 minutes. Our blood loss was 16 cc, 1/6, like half an ounce. And this patient was discharged 2 hours later.
And as long as that segment is not able to move, and there's a much bigger foramen because of this interspinous or the disc spacer, the spondy doesn't really matter anymore, right?
Well, as long as it doesn't cause clinical symptoms,
yeah,
I don't believe it matters. Now, there is two schools of thought, and that is why I'm presenting this. One school of thought is you correct the picture. They don't say that, but they insist on the picture looking perfect, that you reduce the spondy, that you make a 7-degree lordosis to 11-degree lordosis. I'm not kidding you. That you correct those numbers to what you expect. And there is actually a really sad story here. The sad story is here that they get a 75-year-old patient and they try to correct those numbers to a 25-year-old patient. And there's a paper just came out that shows those numbers that they consider normal, they change over the years. Some of these people, they don't try to correct those numbers to the time 5 years ago when you were 65 or 70 years old and you didn't have the symptoms. They try to correct it to what they consider average, but those averages are for 30-year-old, 40-year-old people. And then that requires to do 5 times more surgery to create those conditions. And that is when they talk about that, if you have a good insurance, you get a T5 to S1 fusion. But if you don't have a good insurance, or if you're elderly, you just have to live with that, because that is the only 2 options available. Doing those humongous surgeries or not doing anything at all, because nothing between really correct is able to correct that. You remember we talked about that? Even in this surgery without osteotomy, I could have put screws here in the L3 and have screws in the S1, and then shape the rod and use the rod to bring that segment a little higher. But that would require me to do L3 to S1 surgery, not L4-5 surgery. I mean, that makes inherently sense to Sunny, who's a surgeon and doing this surgery himself. Sunny, you want to comment on that? That, if you really want to use the rod to reduce the listhesis, how that works?
Yeah, so I have one comment on this, Hamid. I think I could have done a regular transcambient olive, because if you look at the anatomy, I have a good picture of the 3-dimensional anatomy of this, pathology. because only thing when you do OLIF, only your concern is not damage the exiting nerve root.
Mhm.
So I would have gone more medially. So
Yeah.
my entry point would have been like quite medial. I mean, you did go choose to do laterally your entry point, okay, in the beginning.
Yeah.
But I think I could have done it more medially. So at that point, my AP would have shown medial edge of the pedicle.
Yeah, I tried
Because
that.
I'm as far away from the
Yeah.
exiting nerve root.
I did that,
Yeah.
and I got getting signal at 2 milliamp. I did
Oh,
it.
you tried to do that first. Okay,
Yeah.
so that's why you didn't adopt this at the first try.
No,
So this is
first
second
try is
try.
always
Okay.
over.
Okay, so these are the nuances that we surgeons deal with, you know.
Yeah, yeah.
Okay,
No.
good.
But I'd like you to comment, if you can, about how, if I wanted to reduce that,
Mhm.
I could, regarding putting, L3 to S1, put a bigger rod, shape the rod, and serially reduce that. I'm
Yes,
sure you
yes.
have
So,
used that technique as well, right?
but I'm gonna congratulate you here because for using the L4 screw and leaving it prod.
Mhm.
Because if you try to sink that screw in, you tighten the rod down, that screw is gonna pull out.
Yep,
And
yep.
that screw will loosen up. So congratulations in leaving the prod. So when we do this procedure, we got to make sure that heads are lined up. So
Yeah.
we don't put undue stress. When we put that tighten that nut down, there's so much force that sometimes the screw will pull right out of the vertebrae.
Yep.
So yeah, so we try to keep it. So if you want to reduce it, you got to go another level. And you use the rod kind of like a fulcrum, and you pull that vertebral body up. But that's just correcting the making the X-ray pretty. There's no reason for that. I wholeheartedly agree with you. We don't want to pull that vertebrae back, and
Yep.
because that puts lots of stress on the screw, and they can loosen up and on and on. So you got to accept. You got to treat the patient, not the X-ray.
And
I totally
and
agree with you.
I wish that wisdom would be widespread, or more widespread than it is.
Treat
Now-
the patient, not the X-ray.
Yeah, that this patient, exactly 2 hours after the surgery, I finished the surgery at 12:30. At 2:15, the surgery center was empty. Nobody was there anymore.
Nice, very nice,
Okay,
perfect.
so we have a little time. I want to show one of the less glorious cases, though. Okay, and this is as well my case. And this is, or anybody, any other comment on this right now? No other comment? So, I'm going to open this case. This is a patient that I did actually beginning of the week. And first I'm going to show you sagittal bone. This is the pre-op. This is actually a patient who flew all the way from Vermont for us. That is more like you, David, okay?
Yeah.
And I'm making it bigger. Typical symptoms, conservative therapy done. Patient has looked into the minimal invasive versus open cases, has typical radiculopathy for this level, and so on. And came to us very, as you see, very skinny, very, not very large patient. And obviously here as well, I decided to do a 1-level OLIF. First of all, any question regarding the clinic, other films, and so on, you like to know about this patient?
She looks very osteoporotic on a CT. Is she osteoporotic?
The bone
Vertebrae
wasn't
looks
too
empty.
bad. The bone
Huh?
wasn't too bad. The bone
Yeah, it
was-
looks very osteoporotic.
and you have a very good point. Very good point. I get to that. But not the most osteoporotic patient. Obviously, this is as well that I think your patient is 65 or something, not extraordinarily old. Any other clinical information you like to have? No? So surgery was a 1-level OLIF, and in the surgery, the films, they were just the graduation of the film wasn't the best. Okay. And now I'm going to go and open the post-op picture. And with the stimulation, generally, David, we stimulate the screws, and if you have direct contact to the nerve root, you get signal as 5, 6, 7, and we generally tolerate up to 8. In the minimal invasively, I generally tolerate up to 15, and the left L5 screw was stimulating exactly at 15. So, and it wasn't really, it's super bad. And I'm trying to see if I have some pictures from the surgery. I think I took some pictures from the surgery. If I apologize, let me just prepare them and show them to you from the surgery itself. Okay. And so that by itself is really nothing out of ordinary, nothing out of usual. Except that, the threshold was a little lower than usual. But let's look at the pictures here. Now, after the surgery, patient wakes up, the left L5 pre-existing L5 numbness is unchanged. Thank you. Left L5 pre-existing numbness is unchanged, and but the pain on the right is gone. Okay, so the patient had prior to that pain on both sides, right more than left, but the left L5 numbness, and that was gone. So overall, if anything, better. And since the patient is from Vermont, I took just a CAT scan. And sometimes, they say ignorance is a bliss. This is one of those. I could have slept much better if I haven't had the CAT scan, because I'm going to show you. Okay, and I'm going to put the coronals here. So I'm going to go down here. You guys are able to see it?
Yes.
So here is the L4s are fine. And the cage is fine. Now look at the left L5 screw. This is the worst screw I have had, at least in the last 10 years. But patient woke up. I would expect, S1 and L5 symptoms here, but patient has no such symptom whatsoever. And I think if you look carefully, that is at least my interpretation of this, that the screw is exactly in the axilla of the L5 and the S1 nerve root. When the nerve goes down, they separate and there is an axilla there. And I have no idea what else could be that this patient had no symptom whatsoever. And now here comes the dilemma. Even a few years ago, and I struggled with that as well, 2 days ago, should I revise it or not? Should I take the patient back and put the screw in the right position when there is no symptom whatsoever? And I still struggle with that decision, so I don't know. So I want to hear your opinion about that. Now, revising it is not a really is not an extensive surgery. If it's a skinny patient, I could have gone there, take the screw out, reposition it, and so on. But patient has no symptoms. So, Sunny, tell me about that. This is our internal case review. So I'm bringing my worst case here. So what do you think? What are your thoughts on this?
Actually, I have a case exactly like this. I did a T10 through L5 fusion for scoliosis. And one of the screws looked exactly like that, okay? And I discovered the problem in a routine CT scan because patient was asymptomatic. So that was 2 years ago. Mm-hmm. And she feels solid. She still have a screw like that and no issues whatsoever. So we have to treat the patient, not the X-ray. I will leave it alone.
Yeah, and that is,
once it fuses, it's gonna be fine. As long as if you will get into trouble if the fusion does not take place and the screw starts loosening.
I
As long
agree.
as fusion gets solid, you don't have any issues there.
Yeah, this is obviously, I'm telling you that a less experienced me would have taken the patient, even asymptomatic patient, directly right away to surgery. And these are truly struggle of a surgeon, Do we want not to be embarrassed?
But let me tell you something, Hamid. After all this, I've been in practice. I've done maybe 20, 30,000 spine surgery last 35 years. In the beginning, straight out of fellowship, first 5 years, I took a lot of patients back. I was nervous and whatever. But sometimes benign neglect is the best.
Yeah.
That's what I'm learning. As I'm aging, I'm getting older and more experienced.
Yeah.
Right? You have to treat the patient, not the X-ray.
And the thing is, the best part of this is somebody coming from Germany to look at the big Abbasi and his performance, and I get this surgery in 33 minutes.
It happens to best of us, Hamid. Even now, it happens to me.
No, but the best
It's a
part
numbers
is
game. Numbers game.
the best part is
Numbers game.
that I do my routine, I get the CAT scan, and I'm putting everything on the table, and the big Abbasi comes with the screw right into the axilla of the nerve root. Now,
I even had a case where it's a re-instrumentation. I tried to put the screw in the same hole the previous screw was in, and sometimes it gets out of the hole. It's obvious things. I mean, it's happened. So I'm going to, David, I think you may or may not know that surgeons are very peculiar about their images. What made for me decision not to take this patient to surgery is that I had a little bit of a self-reflection in me that if I would be doing the surgery, it is only so I don't feel embarrassed.
Yeah,
that would be the reason for me. If I would have taken the patient to the surgery, I would not have done it to give the patient better outcome and so on, as Sunny said. I would have done it so next person who get a CAT scan and look at that doesn't see my evidence of my incompetency, if you want to say, and so on and so forth. And that was for me the moment I said, I should feel embarrassed, but patient shouldn't pay a price for that. So I decided, show it to the patient, discuss everything about that, and say if she wants me, I'm happy to take her, but I do not recommend surgery because she has absolutely zero symptoms from this.
But I think you need to let the patient know, though.
Yeah, I did. I looked at the patient with this, and I went over it, and I told her why is it wrong, and I told her my decision-making process, why I think we shouldn't be doing surgery, and exactly as you said, that when the bone grows, there's really no there is really no consequence of that. That the screw, if it's in the axilla, not pushing on the nerve, really by itself wouldn't cause a problem. And God forbid, if it's causing problem in the future, we still can go and take it out. But even if we wait 3-6 months, if the bone is growing, then we can just take it out, not revise it, just take the screw out if the bone is growing. So I gave all those options to the patient, but I told to the patient that I do not recommend to the surgery. Now, it was a hard decision for me, though, even after all of that, not to take this patient to the surgery and not to revise that. But I think, the future will show what if that was a right decision or not. I hope that this patient fuses, but I'll keep you in the loop. Okay, so then that is my wall of shame.
I think she'll do fine, Hamid. I don't think you don't need to worry.
Yeah. So I think it's important for us as well not show us our glorious cases, but as well cases that are less glorious.
Hamid, I just sent you a cervical case. Can you email you? Can you show that to the?
Absolutely. Let me get it.
The cervical spine, just show people that we do everything, cervical, thoracic, lumbar. Actually, I was in the clinic Wednesday, Thursday in Crookston, and I could not believe it. I picked up 9 surgical cases. I saw 20 patients, and first 7 were all cervical spine surgeries. which is, I think, a record. I mean, you know.
Which email did you send it to?
Huh?
Which
Gmail, to Gmail, I
Well-
sent you the pictures.
Well, I have so many Gmail accounts. Which
Oh,
one exactly?
I sent it to the, let's see. Habasi,
Habasi. Okay, got it.
Habasi, gmail.com.
No, it's inspiredspine.org.
Yeah, inspirespine.org.
Okay,
I showed 4 images, cervical revision case.
I'm getting it.
I just did it. You can show the pre-op and see what the other people's gonna do.
Well, Sonny, I still don't see it.
Oh, you don't see it?
No,
Please, I just sent it to you.
if you send it to, I have so many Gmail's account and
Hmm.
if you want to send it to abasi@inspiredspinehealth.com, that's the best account to send it to.
Okay, let me just, I'll be quick here. Just let me select this thing. This is like revision neck surgery,
No, just abasi@inspiredspinehealth.com. Just abasi@inspiredspinehealth.com.
Oh, yeah, okay. Let me just get this here. So this lady is about 55-year-old, had a multiple previous cervical spine surgery. So we are dealing with a very unsolved problem of adjacent level disease. So this is all regarding how do we deal with the adjacent level disease,
Yeah,
you know? And that's basically it. I think I just sent it to you.
yeah, I'm
So you
waiting.
can look at, show the couple reconstruction images and don't show the results of what was done there.
Okay,
Did you
well,
get it?
I'm still waiting for it. It's not there yet. Oh, it just came. Okay.
Okay, yeah, show the pre-op CT images. So this lady, Graham Fox, and she had some symptoms of myelor radiculopathy from the adjacent level disease as C3, C4.
Is that the one you want to show?
Yeah, that's it. Go show the sagittal. Yeah,
Yeah.
that one. Yeah, show that. So I have not done her surgery before, but she had like several neck surgeries so she's fused from C4 through C7. And she had like titanium cable. She had some screws of unknown instrumentation in the backside. She had big plate in the front and on. But as you can see, she's breaking down. She's going kyphotic at the level above as C3, C4.
Mhm.
And she tried multiple cervical epidurals and chiropractic therapy. Despite that, she's got severe neck pain, weakness, numbness in the arms, and another thing that's happening with these people is they also get a low back pain, which I learned by visiting as a penny surgeon, because they got, in order to take the pressure off the core, they got to bend their neck back forward, and in order to stand up straight, they need to create lumbar lordosis to stand erect. So they get a low back pain as well. So sometimes when you do neck surgery, low back pain disappears. So this actually adjacent level disease. So what would people do with this case? I mean,
Well, let's ask it for the team,
how about Bob? Where's Bob? We'll pick on Bob. He's driving. Where's iPhone man? Bob, what are you gonna do with this case? So neck pain, bilateral arm pain, weakness, numbness.
So, what dermatomes are mostly affected, Sonny?
I think it's pretty diffuse. It's like a neck, shoulder, into the bilateral arms, hands, and
Almost everywhere.
yeah, basically, multi-dermatomal. I think
Mhm.
she's fused from C4 through C7, AP fusion. She also got some titanium cable and some unknown instrumentation in the
I see that
backside.
in the back. I see some of that in the back, yeah.
Can
So,
you hear me or no?
Yes,
Yeah, we
now
can
we
hear
hear
you. Yeah.
Okay, perfect.
So adjacent level disease, Bob, as C3, C4, previous fusion, AP fusion, C4 through C7. I have not done surgery on this lady. He had a left-sided previous incision, like lower mid cervical area.
Okay. Is the patient myelopathic?
No myelopathy, neck pain and radiculopathy.
Meaning, describe the symptoms. Is it back
pain.
of the neck pain and
Neck pain, shoulder pain, bilateral arm pain, weakness, numbness, occasionally dropping objects, some hand clumsiness. No gait disturbance. No gait.
So I will do surgery on this. I will not remove the pre-existing hardware. I'll go in between the C3-4 from the front, carefully.
How are you gonna make a separate incision above the she's got an incision, you know, approximately 5'6". So you will make a left-sided incision or go on the right side? Where are you gonna go?
No, left. Where is her original incision? Which side did they go through?
Left side is the lower cervical spine.
I will do a left-sided horizontal incision to approach C3-4. I will put an interbody cage that is standalone so that I can leave the plate in. And I will do a very careful ICDF, and I will try to reach behind the vertebral bodies to remove some of the osteophytes that are there. Yeah.
That's all you're gonna do?
Foraminotomy as well. And that is all I'm going to do. Yeah.
Just anteriorly. And how long are you gonna keep in the brace? Are you gonna keep in a brace or just?
I typically use a cervical brace for about 6 weeks.
6 weeks.
Diligently, not a soft one, Miami J style, and then I will use soft brace for another 6 weeks.
Are you gonna have her wear the brace round the clock or even
23
sleep?
hours? Yes, even in sleep.
Even sleep round the clock.
Yeah.
Okay. Except for showers only, they take it off.
Yes, exactly. So 23 hours.
You let him take a shower wearing the neck collar, or you take him off, or what do? You let him take off the neck collar when they take a shower?
I do.
Okay.
How about you?
Well, I mean, if I did not do what you did, but
let me tell you what I would do. You know, obviously there is a lot of mechanical stress on that segment. So this
because
is
you
not
got a long lever on below, very stiff level.
Correct. Now, you know, again, talking about fixing the patient, not the picture. Now, is it a steady patient? Is the patient that can tolerate a longer surgery or no? That would influence.
Yes, she's in good health. She's in good health.
So if it's not in a good health, I just would do as a Bob. I just would anterior, even maybe a standalone. But if this patient,
what's the chance of failed fusion? Do you guys think if you do a standalone at that level?
It can be hard, but you know,
50. I would say it's 50%.
Yeah, but as well, if you're doing it on a really unhealthy patient doing a 8-hour surgery as well is a high risk. They can as well die of that. So if this patient is just a healthy patient, there are 2 options you can do. You can do a anteroposterior, which would be a good, and if really bone is soft, you would be even justified to extend it to C2 and so on if the bone is really soft. But if it's, if you want to really limit the surgery, that for whatever reason you decide, doing it anteriorly and then put the patient in a really rigid collar would be an option. If I would do it anteriorly, I would do the double plating, meaning that I put it standalone and then I put a regular plate on top of it. This double plating sometimes can help to overcome mechanical stability. Obviously, not as good as anteroposterior.
Do you think anterior alone, you think you can correct the some of the kyphosis? That's local kyphosis at C3, C4? Because if you accept that, C2, C3 is going to go bad too.
So
you try to correct some kyphosis there, local kyphosis.
You're talking about 3-4, right? That's
3-4, yeah, 3-4.
Yeah. I think depending on the mobility, this decision about doing anteroposterior, this doesn't need to be done from the start. At any point, you get X-ray, you put a cage in, and if you cannot correct that, you still can decide go posteriorly. But there are many factors go into that.
Okay, let's show the results. What do you want to show the result? So I went through the front. I put the cage, standalone cage in there. Then I flipped over and I did that surgery. And I put LNK screws at L3. I have a very good purchase in lateral mass C3. The other one was Medtronic. So I had a hard time finding a screwdriver, but I used the Synthes small fragment set, was able to do the surgery. So the entire case, skin to skin, was 2 hours and 45 minutes. And
Yeah,
the
very
patient
good.
went home the next day. She had no pain after the surgery because I used the Exparel. I injected like crazy into the muscles. And that was the only reason she was able to go home the following day. And her radiculopathy resolved the post-op. And I'm confident that she will fuse because I did the AP fusion.
Yeah, and her posterior is very powerful. For
And
this
I did
patient.
not engage. You see that screw on this? I left it alone.
Yeah.
Because I didn't have a wrench. I didn't need to connect to that, you know. So the
Are these screws
faster the better.
old, or are these screws old, or are they new screws?
Yeah, so the rod was the same size, Medtronic, but I did not have a right screwdriver, so I used a Synthes small fragment set, like AO type of thing, but it didn't have an exact fit, so I had to pound into the nut, try to grab it and back it out of there.
Yeah, well, we know how
used the same
painful
nut.
that is. We know how painful
You
that
gotta
is.
do some gradual work. You gotta
Yeah,
do some
yeah.
improvise it, okay?
Yeah,
But she did
yeah.
fine, so I'm showing this to you.
Very good, excellent. I think it's a good result, and I'll fuse. So it is already 11:02. I think we went through some really good cases today, and so David, we are excited about hearing about the follow-up on your patient.
Follow up.
I'll take Sonny's advice and just sit tight for 6 or 8 weeks.
For about 6 weeks, David.
Yeah, that is something I tell my patient. When you're young, you should find lots of hobbies, because the natural process of aging is going to limit you, take some of your hobbies away. And the best experience I had was a patient that this patient was the happiest patient, and the result wasn't even the best, because still walking was limited, but the pain was gone. Radiculopathy was gone, but the walking was still limited. He loved to do carpentry and lots of other things, but now he goes in his small frequent walks, he finds just trees or branches, and he comes and do on his table, he makes crosses of that, takes it to the church and distributes in church, and he loves to do that. Happiest, the most thankful patient. Now, the next one is my worst case. Another 88-year-old patient, the leg pain is gone, back pain is gone, claudication and the symptoms are gone, but he's so angry with me because he could not drive with his motorcycle to Sturgis for the Sturgis with his 82-year-old wife in the back of the seat. He tried that, and after the 15-minute, half an hour, his back was killing him. He was angry with me because he thought I can restore him to be able to do that. So these are my best and worst cases. And my advice always to people is, have a lots of hobbies, because life is going to take some of them away. So you need to have more hobbies. If driving to Sturgis, your 82-year-old broad, is that the only thing that gives you joy in life, you will be disappointed. There's really not much I can do about that. Okay, well, thank you everybody for joining us today. And next month in August, we are going to have our, we have our case conference, and we have our, I'm hoping we have our symposium. The information will be distributed to you, and we really would love to hear about your ketamine treatment, David, if you can. Okay.
Okay, sounds good.
Thank you, everybody. John, stay on. Thank you.
Thanks. Bye.